Let me introduce our third speaker, Professor John Morris. Professor John Morris is a distinguished professor of neurology at Washington University School of Medicine, USA. He is also the director of Charles and Joanne Knight Alzheimer's Disease Research Center. It's our honor and a pleasure to have Professor Morris to give us a lecture about Alzheimer's biomarkers in healthy aging predict cognitive neuropathological outcomes. Professor Morris' research focuses in dementia, geriatric neurology, neurodegenerative disease, and cognitive function. He will discuss the use of the molecular biomarkers, specifically A-beta and tau proteins, as a reliable indicators for Alzheimer's disease neuropathology even in asymptomatic individuals. Let's welcome Professor Morris.
Well, thank you very much for the invitation to join this very this conference. I'd like to thank particularly National Health Research Institute and the other sponsors, as well as the organizing committee. So here are my disclosures. Our research is supported primarily by grants from the National Institute on Aging, part of the National Institutes of Health in Bethesda, Maryland, and have no conflicts with pharma or biotech companies. I want to acknowledge that I think a reason that I'm here is because of my association with John Yang from Kaohsiung University. John came to visit us in 2000. So we had a long and productive association, and I thank him very much for his support. Information that I'm going to present here today, of course, are done by a team at Washington University in the Knight Alzheimer's Disease Research Center, and I want to acknowledge particularly Tammy Benzinger, Rick Perrin, Suzanne Schindler, Kenji Zhang, and Justin Long. And Justin published the data that I'll be presenting in the first part of this presentation. So the purpose of this conference in large part is to try to think of ways and develop strategies to promote a vital and geriatric society so that we have people who are thriving rather than than affected by disease. And of course, we have to address then, to achieve that goal, really global aging health issues. And among those health issues, one of the most, perhaps the most challenging, is that of Alzheimer's disease. So we, over the past 2 or so decades, have developed a paradigm wherein we look at Alzheimer's disease as a entity that really has a long asymptomatic period. We call it preclinical Alzheimer's disease, wherein the pathophysiologic changes are beginning in the brain but have not yet caused enough neuronal or synaptic damage such that brain function fails and dementia appears. The reason we've been able to identify this preclinical Alzheimer's disease in cognitively normal older adults is because in the past 2 decades or so, we've introduced molecular biomarkers of this pathophysiologic Alzheimer process, both imaging biomarkers as well as fluid biomarkers, primarily cerebral spinal fluid. And we know that the first abnormality is dysregulation of amyloid levels in the cerebrospinal fluid. And as I say, this may begin some 20 or more years before dementia appears. It is then followed by amyloid imaging positivity, and then later on by elevation of cerebrospinal fluid tau. So in this paradigm, the symptomatic phase of Alzheimer's disease, which lasts some 7 to 10 years, is really the end stage of this long process. And although there now is hope for disease-modifying therapies for people with symptomatic Alzheimer's disease, our idea is it would be much more effective to try to prevent this end-stage symptomatic phase of Alzheimer's disease by identifying the preclinical stage of Alzheimer's using biomarkers and then intervening with agents that can halt this pathophysiologic process and at least delay, if not prevent, Alzheimer's dementia. So the molecular biomarkers of Alzheimer's disease include amyloid and tau PET imaging, as well as cerebrospinal fluid, and now plasma measures of the major proteins that are disrupted, amyloid beta and tau. We know that using biomarkers that about 30% of cognitively normal people age 70 and over are positive for one or more of these biomarkers. The question is, when in the lifespan do the biomarkers first become apparent? And as I mentioned, we think this is at least 20 years before symptoms occur. So if people over 70 are the predominant age at which people dement, that means the biomarker positivity may begin at age 50 or even younger. So we have always been studying people 65 and older, but for the past 20 years, we've initiated an adult children's study of middle-aged individuals, age 40 and over, and in fact can find amyloid abnormality beginning at about age 45. Biomarker positivity is now mandatory for individuals who want to participate in clinical trials of potential Alzheimer therapies, and now for the approved disease-modifying therapies for Alzheimer's disease. The first such drug, lecanemab, was approved in the United States in July of this year. But you must demonstrate that people have abnormal amyloid, because lecanemab is an anti-amyloid antibody, and you don't want to administer it to people who do not have the target. So we use biomarkers quite a bit to understand the course of Alzheimer's disease and now for therapeutic purposes. But few studies have validated these molecular biomarkers with the cognitive and neuropathologic outcomes. So that's what I'd like to present here. A study of cognitively normal individuals who had one or both of the imaging and fluid biomarkers. These individuals were aged 42 to 91 at their initial examination. They either had amyloid PET scan or they had CSF measures. We used the phosphorylated tau at 181 to A beta 42 ratio to identify people with a positive biomarker signal for Alzheimer's disease. So we assessed whether these individuals who had biomarkers and were positive, did they progress to cognitive impairment eventually? And for those who came to autopsy, did they have the neuropathologic findings of Alzheimer's disease? We used the Alzheimer's disease neuropathologic change criteria and required them to have at least intermediate or high likelihood that the Alzheimer's pathology was responsible for the dementia. So these are the demographic characteristics of these individuals in this particular study. We had a total of 720, of whom 79% were biomarker negative and 22% were biomarker positive. The biomarker negative individuals, as expected, were younger and had less likelihood of carrying an ApoE4 genotype than the biomarker positive individuals. Note that the mean educational attainment for this sample is essentially a college degree, 16 years of education in both, so this is not a sample that is representative of the general population. There were no sex differences in these two groups, biomarker positive and biomarker negative, it was predominantly a non-Hispanic white population. About 50% had both amyloid PET and CSF. If they had only one biomarker, they were more likely to have amyloid PET than they were to have cerebral spinal fluid biomarkers. So over time, about 34% of the cognitively normal biomarker positive participants did develop dementia versus about 8% of the biomarker negative participants. For those individuals who were biomarker positive and became demented, the clinical diagnosis was that of Alzheimer's disease in 80%, whereas for the biomarker negative people, it was only 55%. So other factors may be contributing to the progression to dementia in the biomarker negative individuals. Neuropathologic outcomes, so we had 82 of the 720 individuals die during the study. And of those 82, 70% or number 57 came to autopsy. And here, 91% of the biomarker positive participants had intermediate or high Alzheimer's disease neuropathologic change versus only 8.6% of the biomarker negative persons. Now, if you look here, these are false positive individuals. That is, they were biomarker negative, but did not have sufficient neuropathologic change to meet our criteria for Alzheimer's disease. But notice, this is on amyloid PET, that they are at the very threshold for positivity, so this may be a threshold issue. So for the sensitivity and specificity characterization, individuals in the total sample using both amyloid PET and cerebral spinal fluid had, for predicting neuropathologic Alzheimer's disease, sensitivity was 87%, specificity 94%. If we use the CSF ratio of p-tau 181 to A-beta 42, note that the specificity is 100%. So we did have a false negative and two false positive cases. I've already mentioned that the false negative cases were very close to the cutoff for amyloid positivity, so may suggest that we should change that cutoff value. And I mentioned that the clinical diagnoses in the biomarker negative people who progressed to CDR greater than 0 had clinical diagnoses of non-Alzheimer's disease much more frequently than our biomarker positive people. And we found that neuropathologically as well. For the biomarker positive people, non-Alzheimer pathologies were infrequent, whereas among the biomarker negative people who progressed, they had vascular lesions, TDP-43, and synucleinopathy. So we concluded that preclinical Alzheimer's disease biomarkers are associated with a significantly increased risk of developing dementia and are highly predictive of intermediate to high Alzheimer's disease neuropathologic change. Now, some of our biomarker positive people did not progress over the time period of our study, and some of them stayed CDR0 for more than 15 years, and this is just consistent with the fact that the duration of preclinical Alzheimer's disease may be 20 years or even longer. Of course, these individuals also may have factors that give their brain resilience to the neuropathologic changes. Now, I already indicated that our sample is not representative of the population, and we do need to study the frequency and predictive value of biomarkers in minoritized groups, not just in non-Hispanic white individuals. And already the little data that we do have that begins to emerge suggests that Black and Hispanic individuals have overall a higher rate of dementia compared to non-Hispanic individuals. But the paradox is, in a few studies, and there have only been a few, Black and Hispanic individuals seem to have a lower rate of amyloid positivity and amyloid burden. So this is important because we want to incorporate Black participants in clinical trials of anti-amyloid or anti-Alzheimer drugs, but to be eligible for the trial, you have to be amyloid positive. And if Blacks have a lower rate of amyloid positivity, they will be underrepresented in the clinical trials. So why would this be the case? Why would, if they have more dementia than whites, why would they have less amyloid or Alzheimer pathophysiology? Well, there are selection biases that are at play. White participants may come from a different source than Black participants. And there is the increasing importance and attention to social determinants of health, particularly over a life course where experience of chronic discrimination and racism, lower quality of education may indicate increased risk for Alzheimer's disease. And there may also be genetic variants that affect the biology. And then finally, Blacks and Hispanics may have higher rates of other conditions, comorbidities, that may increase risk for non-Alzheimer forms of dementia. Now, I've shown here effective treatments, and I underscore for all patients. These are data from the lecanemab study, and note that that positivity, a positive response, is associated with most individuals, but not for individuals who are ApoE4 homozygous. In addition, note that younger people below 65 may not benefit from the drug, and individuals who are women also may not benefit from the drug, as well as individuals from non-white groups. So again, this is just underscoring the importance of enrolling individuals that represent the population, not just individuals who tend to come into studies such as the one I presented. Now, we have been, as I indicated, doing biomarker studies for 20 years in research cohorts. Now, with the advent of disease-modifying therapies, lecanemab is only the first, others are coming and soon. We must utilize biomarkers much more widely to find out who is eligible for therapy. Biomarker confirmation of amyloid pathology is mandatory in patients being considered for these new treatments. But PET scans are only available at academic medical centers. They're expensive, they have radiation. Cerebral spinal fluid requires spinal tap, lumbar puncture, and these are not going to be widely used in the population. And again, we need to study the entire population, not just individuals who volunteer for longitudinal research. So now there is great interest in and work being done on blood-based biomarkers, these promise much more rapid and accessible diagnosis to determine who is eligible for these treatments. Also, they likely will be much less expensive than PET scans and much more tolerated than a spinal tap. So we have been at Washington University, as well as many other centers, been examining blood-based biomarkers for Alzheimer's disease to determine amyloid status. There are many blood-based biomarker tests in clinical use or under development. I'll mention one because this was developed by my colleagues at Washington University, Dr. David Holtzman and Dr. Randall Bateman, where they had formed a company called C2N, which developed a blood-based biomarker using immunoprecipitation mass spectrometry. And the company has developed this test called Precivity, first based upon amyloid beta 42 to 40 with ApoE proteoforms, but now they've developed a Precivity 2, which incorporates the amyloid beta 42 to 40 ratio, but also p-tau 217 and amyloid beta 42. And it has a very strong sensitivity and specificity. But many other companies and platforms are being developed to determine their utility for blood-based biomarkers for Alzheimer's disease. Now, in our hands, what we find is the various tests do show the strongest value for the plasma A-beta 42 to 40 and the p-tau 217. And combined, they have remarkable ability to identify amyloid-positive individuals. This is just a overall view of what we can detect first. The the p-tau 217 in the cerebrospinal fluid seems to become abnormal first, some 21 years before people develop cognitive impairment, as indicated by estimated year of onset of impairment. But p-tau 181, which is much more widely used, is also very good at identifying the early stage of the disease. Both p-tau 217 and p-tau 181, even though they are based upon tau, are much better indicators of amyloid deposition than they are of tauopathy. So these are really measures of amyloid. p-tau 205 is a better indicator of tauopathy, p-tau 205. So we should develop these blood-based biomarkers because they will be much more accessible, much better tolerated, and hopefully much cheaper than PET scans and cerebrospinal fluid measures. We think that the p-tau 181 to A-beta 42 or the p-tau 217 are the best markers to determine in the CSF amyloid status, and in the plasma that p-tau 181 and p-tau 217 classify amyloid status at the earliest stage. So I think as more disease-modifying therapies come to be available and more individuals are being characterized to determine their eligibility for treatment, we'll see a corresponding increase in the acceptance of blood-based biomarkers for Alzheimer's disease. With that, I thank you for your attention.
Thank you, Professor Morris. Excellent talk. He mentioned a lot of innovative biomarkers, including the amyloid and also blood-based biomarkers to detect early detection for the Alzheimer's disease. If you have any questions, please hold on the last section. We have a discussion section.